Well, hello, everyone, and thank you for being here. I just want to say I have been really looking forward to this session because I think the conversation about women's health has never been more important. And, especially tonight, I think. And I wanted to really kind of lay the groundwork for where we are right now because on the one hand, I don't think we've ever had more science, research, technology, and innovation dedicated to women's health ever before than we do now. But on the other hand, politically and socially and even policy-wise, I think it's an environment that's really difficult, right? To put that new knowledge into practice. So I'm gonna get your thoughts on that, but I wanted to start with the state of the science, because I think that's very exciting. So Kate, let's start with you. You created Maven Clinic 10 years ago because you saw a really big need. So congratulations on the 10-year anniversary, first of all.
Thanks, we're still alive.
And tell us what gaps you saw and what needs you really wanted to fill with Maven.
Sure. So 10 years ago, I'm going to date myself, but my friends were just having kids. I just turned 30, and it was pretty amazing to have gone through my life where I felt things were equitable. I was a good student, kind of naughty, but pretty good, a good athlete. I loved the last panel. And then that second you have kids, everything becomes so different. And I watched some of my friends go through journeys like infertility, postpartum depression. My first pregnancy ended in a miscarriage. I have 3 kids now today, but it was pretty astounding that our healthcare system, which is often dominated by the female consumer and women as the chief medical officer of their homes, that entry point for us was just so underserved. And so I saw it firsthand. I then experienced it myself firsthand and thought, okay, we're also living through a time where technology is coming to healthcare, and of course the pandemic massively accelerated that. But 10 years ago, no one really knew what telemedicine was, but it was coming. And so I thought, how do we leverage the best of digital health, the best technology, but then really build a model and a care model around equitable access for women and families and putting them at the center of the healthcare system. So that's what we do. And 10 years later, we have 2,000 clients today that offer Maven to over 17 million people that have fertility benefits, pregnancy benefits, postpartum, pediatric, and menopause benefits through Maven. We're still, I feel like, just at the tip of the iceberg. And I think what's been notable, as you said, is that in some ways we've made great strides. In other ways, we've had major step backwards in the last few years. And so there's a lot to still talk about and do in women's health.
So I've covered health for more years than I want to admit, but so I'm very familiar with those barriers that you're talking about. We hear about women who are diagnosed with heart disease later than men because their symptoms aren't taken seriously. We hear about women who are reluctant to go to doctors with symptoms because they're, likely to be dismissed. How did you create Maven? What was your thought in terms of how did you reduce those barriers and make it easier for women and more accessible for women?
Sure. Well, I thought, if you can just have everyone had a clinic in their pocket of providers who deeply cared about you, but also maybe shared your lived experience, were your same gender, your same race, spoke your same language, were your same sexual orientation, that you would have this little circle of trust of providers in your pocket that you can whip out at any time as you're going through the in-person system and the bricks and mortar system to really help guide you and navigate you. And so what's been really amazing is over the last 10 years, we've now taken this virtual model and we've been able to actually attach it to real clinical outcomes where this virtual model, yes, we don't deliver babies, but we actually can reduce C-sections by up to 15 to 20% in a population just because we're empowering people with advocacy. Or on babies born prematurely, we're able to reduce NICU admissions by up to 15 to 20% in some populations, which is huge. And so fertility, same thing. The IVF journey is really fraught, and now, both because of the care model, but also because we design the benefit and we process the payments and we can design a better model with better information. One kind of crazy thing in the fertility space right now is there's so much misinformation. We just did this big study where we looked at TikTok, and 75% of all videos on TikTok about your fertility are by non-doctors, or they're not physicians or medical providers. 40% of the information is wrong, and this was all because we were following this trend where there's all these Mucinex videos on how taking Mucinex will help you get pregnant. So there's just so much going on right now. We're even in the fertility space, to just be able to have that trusted information in your pocket to help navigate things, menopause, getting HRT prescriptions at the tap of a button. It's been amazing to see what a little old virtual model, that one though that is culturally competent and really prioritizes women and families at the center, we're actually providing better member experiences, reducing the cost of care. And so this is why we work with so many different players across the system.
So I think it's a great example of how technology can be a double-edged sword, really. So Dorothy, I wanted to ask you about Aura, because I found it fascinating that your demographic has changed from being primarily male when you launched to now 60% female. So can you tell us about kind of what you think is behind that shift and how that's perhaps changed some of the priorities for Aura as well?
Yeah, so for many years, wearables have really been made for men by men. And it's kind of, it reflected in the products, and a lot of women sort of felt a little alienated from them. One of the things that we've done in the last few years is really invest in the research and the studies to make sure that we understand women's physiology. I have to admit, and Kate, you can laugh at me, but I am one of those people who was on the TikToks and on the very...
Most people are.
looking for answers. Right. And it's because I think for a lot of us, myself included, you don't know where to go to get them, right? And we go through life and we learn all these amazing skills about a lot of things, and we still don't understand our bodies, particularly as women, because they are fascinating, first of all, and they're always changing. And when you start to understand the ebbs and flows of it, it becomes almost like a superpower. It's like, I know what's happening. Most women don't know what ovulation is when they get to the point in a journey where they need to decide their reproductive health and what their family planning is. And that just feels like we're robbed of this. So one of the things that we've done at Aura is really invest in features that actually let you understand that. So not just when your period is due, but actually what's happening during the different cycle phases.
So like the information that everyone is desperate
Totally.
for. Yeah.
Everybody wants to know, so that you don't have to kind of rely on bad information or go searching down, in my case, like a Reddit rabbit hole late at night and hope
We've all done
the
it.
answer.
We've all done it. Kaleni, I wanted to talk to you about equity in healthcare, because both, Kate and Dorothy have talked about, the gaps there and how the experience in healthcare is very different for women. One of your surveys showed that 1 in 5 women said that they, didn't get healthcare because they were concerned about the cost, and studies consistently show that women disproportionately pay more out of pocket than men do for their health services. Tell us a little bit about why that is.
Alice, there's so much in that, right? And I'll start by saying, with the stories that you've told, I often describe myself as an idealist with a broken heart, right? And that's because I've been in healthcare actually for about, I'll just say over 25 years. And in that, what we've seen is that there are barriers and obstacles to women accessing healthcare, which starts with the science of it, right? So imagine this. It wasn't until the early 90s, 1993 to be specific, that there was a mandate to include women in clinical trials. So what does that mean? It means that we have this whole body of knowledge that it's not that you don't know what ovulation is, it's like the whole medical world doesn't understand how women's bodies work, right? And I think it's really critical, because when you think about how we make decisions about what care to allow, what benefit coverage to provide, how to do cost sharing, the decisions are made on a default of a standard 70-kilogram white male. So when you look at that, it leads to the two things that you've mentioned. One is that, and it's actually 1 out of 2 women, 50% of women have said that they've delayed care in the last 12 months because they either couldn't afford it, couldn't find a doctor, couldn't get transportation to go to a doctor, couldn't find someone to care for their elder or their child when they needed care. That's a problem. But then you take the average woman, and when we look at the studies, it shows that in the US, women pay collectively $15.4 billion more in their out-of-pocket costs to receive the care that they need. That averages out to be about $250 per woman per year. And I've seen the bags that people carry, so you're like, what's $250? I've been watching. But what I will tell you is 44% of women say that they are not prepared to pay an unexpected $500 bill. And so what that adds up to is the science isn't there, the evidence doesn't understand us. Decisions are made based on existing evidence. And there's a pay equity gap that folks have already talked about that adds to this pink tax that women have to accessing healthcare. So it really creates not just an unequal system, but an inequitable system, which means the system doesn't recognize that physiologically, biologically, socially, there are differences between the sexes and the genders.
Kate, I want to ask you about that and ways that Maven is addressing those inequities and finding ways to either increase access or improve, the information and the care, the education that women are getting.
Sure. Well, first of all, Kalani I met a few years ago, so I'm so excited about the work she's doing because she's doing it inside of a huge consulting firm and really tying a business imperative to health equity, which is so important to actually make progress. So our perspective, similarly, is you have to measure it, you have to prove the ROI, you have to prove the outcomes if you're going to make any progress. And so one of the things we did is when everybody comes into Maven, some of what Kalani was talking about is like social determinants, right? Access. If you don't have access to food, to transportation, to get to your medical visits, there's just major barriers to getting care. And so we have a very short survey that we actually, our chief medical officer kind of created and published because some of the surveys were just they were too long. And so it's 3 questions and it's really measuring, what are your needs? And then it's matching you with a care advocate on the Maven platform who can address some of them if you are vulnerable and at risk and have some of these barriers. So that's one thing. I think, well, women's health is one big health equity issue, so let's be honest. I always like to start there too. I think we do work in Medicaid, so we're in 7 Medicaid markets today. We just signed a big national contract with a payer, so we'll be in about 6 more markets next year. I think people forget that 40% of births in this country are born onto Medicaid, moms on Medicaid plans. And so what that means is like almost 1 out of 2 children in this country are born into poverty. That is, and it's going up in certain states right now. And in some states, that rate could be 65% of Medicaid births. I mean, these statistics are terrible, and so those are the most at-risk populations. And so, particularly with those populations, sometimes it really is just giving them a provider that's accessible, that they can trust, to help them even just understand that they should take a vaccine. This was something we did during COVID. A lot of women who were pregnant didn't want to take the vaccine. They didn't understand the science, and they didn't care about the science. They don't understand that they don't trust the healthcare system. They don't trust the providers in their community. So why would they take some vaccine? And so what we were able to do with some of our partners in Medicaid is to say, okay, here's a provider on Maven who can just kind of talk to you about it, and maybe they share your lived experience, or they're your same race, they speak your language, and they can just help you feel more comfortable. So, providing that access to those providers that give you that comfort, and then also kind of for us understanding who's at risk in populations, and then matching them with some of these services through our partners that we deliver care through, is something. I mean, it's not enough, right? But at the end of the day, I think the biggest opportunity is the more data you can bring out of this, and the more we can measure, we can continue to partner with people like Clenny and put that out in terms of a path forward. Because I think there's a lot of goodwill in the system on health equity, but there's not a business model yet for it. And so that's what I think a lot of us are up against.
I'm glad you brought up data, because I think that's the key to what you were talking about in terms of trust as well, right? So Dorothy, I wanted to ask you, at Aura, it seems like your device and your platform provides a great and fertile ground for collecting some of that data that we really need, to understand about period cycles, about menopause. So tell us a little bit about some of the data that you're collecting.
So we collect over 50 different biomarkers across the person, and that data, we take data privacy very seriously. We're GDPR compliant, and we make sure that everybody understands their own data, but also how they can protect it. What is interesting, though, in the world of data is that most people don't know their own data, right? You go to a doctor's office, and it almost feels that it's like behind a sort of a vault that you can't get to. And so for a lot,
you're not even supposed to know.
That you're not
right?
supposed to know, or that you don't understand it. And as you've both pointed out, it isn't easy for many people to either get to a doctor's office, or it isn't easy for them to interpret that data. So being able to understand your own data and having access to it at all times, that's just really key. I think this is particularly true in the world that's changing in technology, where we have a lot of change in AI. And what that is giving us is access to all these really exciting tools that could eventually allow people not just to get more data, but to actually understand it and interpret it. So I'm excited to see how those changes start to actually improve health for people too.
Well, all of you are must have read my notes, because my next question was going to be about AI. And so you've talked a little bit about how you're looking at incorporating it. I wanted to ask Kaleni and Kate as well about, there's been a lot of back and forth over both the promise and the peril of AI, of course. And it isn't just limited to privacy, but this idea of kind of depersonalizing, right, healthcare just at the time when we need more personal and individualized care. Can you address how you view AI in healthcare? And we're beginning to see a lot of big healthcare systems start to adopt it. Can you address how are you worried about it, concerned? Are we doing enough, ahead of time to prepare for making sure that it's used in the correct way?
So the answer to that is super simple. It's yes and no, right? And what I mean by that is, AI is a tool, right? So if I asked all of you, how many of you believe in a stethoscope and that it works, right? And then if I said, what about ultrasound, right? But there are lots of technologies that have come in place. And what I would say is we are investing in an AI appropriately, but there's probably more we could do. But there are 4 things that need to be proven out before we can actually trust what AI can do. And the first one is capability, meaning, are the organizations that are using AI able to actually address the needs that we have as women? And I think Kate Maven is a great example of where there's proof points that there's capability, right? And in capability, we talk about front office, which is, can it schedule you? Can it get you to the right doctor? Back office, can it help you pay your bills? And then in the middle, can it help with decision making? So there's a capability component. The second component is reliability. Love that all this data is being collected, but we've seen in the news cycles of the hacks, and are these organizations reliable to protect your data? That's really important. The third, I would say, is transparency, which is, are they actually going to tell you how they're going to use the data? Are they doing something else with your data that you're not aware of? And then the fourth, and probably the most important for us as women in this time where policy, political, social, and technological advances are coming together, is the humanity, which is, are you going to use it to my benefit? When you control the data, or you have the data on my menstrual cycle and what I ate for food, how many hours I slept, what is your intent? And I think that we have to get that narrative right, and so that we can have women have the confidence. Now, I will tell you, in the studies that we've done, women do want to use digital technologies related to maternal reproductive health and all other things. And I think AI actually has the ability to take that paucity of data and give us new insights so that even cardiovascular disease, which is the #1 killer of women, not part of the bikini medicine that you normally hear about, but to give us the insights that we need to care. So I think there's a lot of promise and potential, but like any tool, it can be used for good or it can be used for bad.
Kate, is there anything you wanted to add in terms of how Maven is looking at AI right now?
Sure. So, I mean, we as a technology platform, of course, we're really excited by it. I share, there's definitely, from a society standpoint, like lots of things we should be considering. Inside of Maven, I think the opportunities are endless on personalization and drawing connections between how our patients are seeing different providers on Maven, helping our providers kind of better treat our patients, help them connect to other providers in our platform. There's a lot of passive data that we can ingest, whether it's Apple Watch data, genetic testing, to kind of connect all the dots for our patients so that we can get ahead of early warning signs to, help our patients have healthier outcomes. IVF, there's just so much that's still not known. I mean, the fertility journey is kind of crazy in the sense that sometimes it's just down to like a doctor's intuition and protocol in terms of what makes a successful cycle or not. So there is so much that AI can do to help improve IVF outcomes. On menopause, like no one's really studied that. So I mean, as all of these companies, Maven included, are collecting all of this data, there's a lot that actually, one of our theses in the whole space is women's health is so far behind and has had more gaps in how care is delivered than so many other parts of healthcare. Well, let's use that to our advantage. And so in menopause, great, we can actually build better foundational models now to leapfrog other areas where there's more tech debt, so to speak, and so, or healthcare debt. And so inside of Maven, we're really, really excited, but we share a lot of making sure that, there's not bias in it as we're using some of these LLMs and making sure that we're doing it in a way that, we're going to do it well for patients, but I think as a society at large, we have to make sure that it is used and harnessed in the right way.
Right. And speaking of that, kind of like the double-edged sword, I did want to ask each of you about, we've been discussing sort of the positive side and the innovations that we're seeing in women's health. Still have a long way to go. But at the same time, the political climate that we're in right now, especially here in the United States, is challenging for women's health, whether it's reproductive rights or access to IVF services. How concerned are you about where we are now? And do you see, if we look back 10 years from now, is this going to be like a very pivotal transitional period in terms of what we do now, what we decide to do now, policy-wise, advocacy-wise?
I mean, I'm just really sad because so many people are suffering right now as we figure it out. And so I hope that as we get more and more data on maternal morbidity, maternal mortality in states with restricted access, that we are able to move policy faster, because it is so sad what is happening to so many families right now in states where they can't, there's just major barriers to care.
Yeah, and I would add, if you look at preventable deaths, not just in the US, but globally, it's not changes and differences in clinical care that actually lead to preventable deaths, right? It's the drivers of health, which are social. Do you have connections? Are you alone? Do you have people to care for you? Do you feel included? Environmental, which means do you have clean water? Do you have clean air? And economic, which means do you have the ability to pay for the services that you need? Can you pay for healthy food? But Alice, to get to your question about the political determinants of health are just as real as the social, economic, and environment. And anybody who doesn't believe it can just look at housing policy and educational policy and look at the outcomes we get based on the policies that are passed. So I feel as if we are in a precarious situation, which means we're not powerless, but if we don't use our power, we're going to regret it.
Dorothy, you have any comments on that?
Yeah, I think, probably like many people in the audience, I waver on a day-to-day on how hopeful I feel and how terrified I feel. I do have moments where I see hope. I'm hopeful tonight that we have a good outcome. But I'm encouraged by what I see in younger demographics. And I'm really encouraged particularly by how they are using their voice to stand up for what they believe in, particularly when it comes to their own female body rights and reproductive rights. And I think that that is really where a lot of the momentum is going to continue.
Great. Well, Kate, Kaleni, and Dorothy, thank you so much for your time.
Thank you.
Thanks so much.
And let's all remember to use that power.